Welcome to our live webinar titled Hereditary Predispositions for MDS. Thank you for joining us today. My name is Lee Clark, patient educator, and I will be moderating the presentation today. As we get started, I would like to recognize the generosity of Bristol Myers Squibb, Jazz Pharmaceuticals, Agios, Genentech, and Takeda for their generous support and the generous support of our patients, families, and caregivers for supporting this webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or a comment, open the Q&A window in the lower part of your screen. Type in your question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I respectfully ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Sarah Bannon, who is a senior genetic counselor in the Department of Clinical Cancer Genetics at the University of Texas MD Anderson Cancer Center. Her clinical responsibilities include providing risk assessment and genetic counseling services to individuals at risk for an inherited predisposition to hematologic malignancies. She is the genetic counselor for the Hereditary Hematologic Malignancies Clinic. Thank you, Sarah, for joining us today.
Great, Lee. Thank you so much for having me and for inviting me. I'm very honored and privileged to be here in my home. Apologies in advance for any cats. And I would love to share with you guys about our emerging and upcoming knowledge about hereditary predispositions to MDS. We can start. Great. So for about the past 6 years, I've met pretty much exclusively with people diagnosed with myelodysplastic syndrome and acute myeloid leukemia. And it's so natural and so reasonable for the first question when anything happens, not just MDS, but when we get a diagnosis, one of the first questions that can often cross people's mind is, could I have passed this to my children? Could my family members be at higher risk? And some of you, actually many of you, might have even asked your doctors that very question. Next slide. So to give you a little bit of perspective, a little bit of sort of a timeline, the first published report of a familial blood cancer was actually in 1944. You have to click back a lot of pages in PubMed to get to the first report. And it was a case of 2 chronic leukemias in the same family, but it was the first time that there was any sort of report in the medical record about multiple blood cancers in one family. You can click. But it wasn't until 2001 that the first susceptibility gene for myeloid leukemia, which included MDS, was published. And that's the RUNX1 gene, which we'll talk about a little bit later. But to give you a little bit of perspective, early 1950s was the first bone marrow stem cell transplant for an acute leukemia. 1970s was when leukemia was associated with a rare pediatric disorder, but not MDS. And the BRCA genes are the BRCA1 and 2 genes, which link with hereditary breast cancer, which have gotten a lot of public knowledge and a lot of time in the popular press, were discovered in the early 1990s. So really the field of hereditary forms of MDS starting in 2001 is super new. Next click. And actually, when I say super new, I mean in the last decade. So in 2014, we had about 3 known hereditary predispositions to MDS. And since then, over 15 genes that cause MDS to run in families have been identified. And so I have my little thought bubble there saying that seems recent, and it is. And it's new for doctors, it's new for genetic counselors, and it's new for patients. And so by partnering together, even with this webinar, hopefully we can start to continue to raise some awareness about this. Next slide. So none of you here are strangers, unfortunately, to what MDS is, but it's important to have a little bit of understanding of MDS and how exactly it happens to help us understand how it can be hereditary. So as you know, MDS is a group of blood disorders. So there are multiple different types of MDS, which ultimately all affect the way that our bone marrow makes the right number of healthy blood cells that can do what they're supposed to do. White blood cells to fight infections, red blood cells to carry oxygen, and platelets to clot our blood. Now, of course, MDS is rare. So there are only, a couple tens of thousands of cases diagnosed in a year, whereas there are, 400,000 cases of breast cancer every year. So if you look up the top 10 list of most common cancers in the United States, MDS is not going to make that list. So it's pretty uncommon, which means when we see it in multiple people in one family, the odds of that, the statistical probability that that could happen is actually pretty low. And as you all know, MDS is usually considered an age-related cancer. So most people, about 3 out of 4 people diagnosed with MDS will be diagnosed over the age of 60, and on average in the late 60s to early 70s when the diagnosis is made, which means it's only about a quarter of patients who are diagnosed under the age of 60. So to have a rare cancer at a rare age is also one of the things that we'll talk about in this webinar. Now, a couple of things have been identified to cause MDS besides aging and the fact that it can happen just by chance. And that usually has to do with chemicals that we might have been exposed to, like benzene, for example, or treatment for a previous cancer. It's one of the worst things in the world to get another cancer related to the treatment you had to get for a different cancer. But those chemotherapy agents and the radiation we use to treat or reduce the risk of a different type of cancer can, of course, cause MDS as well. But as we've recently discovered, again, really new in the last 10 years, there are some genes that run in families that can predispose to MDS too, and that's what we'll be focusing on. So MDS, to understand the hereditary form, we first have to talk a little bit about genes. And for most people, it's been a while since you've had to think about genes in terms of, thinking way back to high school biology, unless you're a biologist, in which case, welcome. And humans have about 25,000 genes. We only know what about 2% of them do. So, but the ones we do know about really guide and direct our biological function. So genes are just this massive blueprint for exactly what needs to happen in our cells for our bodies to be able to grow, develop, and thrive. And so since genes are the units of heredity, they're how we pass on traits to our children. You can see genes for eye color, height, but also for disease predisposition. And there are a lot of genes that are important specifically to how our bone marrow works. So if you think about the bone marrow like a factory, like it is, it has to make the right number of blood cells and the right type of blood cells. It also has to respond to our environment, right? If we are exposed to a bacteria or a virus, that tells our bone marrow has to get the signal to make white blood cells and to amp up our immune response. And so there's a whole set of genes that are like the managers for that system who are in charge of saying, okay, we need this many platelets and we need them now. And so those genes are really important. And in some families, there are mutations or errors. And I don't like the word mutation too much. For a genetic counselor, I should love it, but mutation sounds too science fiction-y, but a mutation is just a change or an error that occurs in that gene's instructions so that when it's trying to communicate to the bone marrow how many platelets to make, it's not always able to do that perfectly or the message is getting lost. And so a mutation or an error in one of those genes can lead to bone marrow problems like MDS, can increase that risk, but can also be passed to children too. Next slide. So The good news and the takeaway from this is that most of the time, MDS is not hereditary. It happens by chance or due to just age, or also exposures or previous chemotherapy or radiation treatment. So most 70 to probably 90% of MDS just happens by chance. It's a small percentage, about 10 to 30% of MDS that may have a hereditary cause. Now, the high end of that spectrum, 30%, seems pretty high. And I want to make it very clear that MDS predispositions are so new that we haven't been able to do any studies looking just at these genes linked with MDS. It's always including AML, which of course is sort of the risk that MDS can progress to, that acute myeloid leukemia. And so since sometimes we don't find out someone has had MDS until they develop AML, and we look back in their bone marrow and say, oh gosh, this has been brewing, this was MDS before, it's really hard to get a study that's just looking purely at MDS. So when we combine those two together, MDS to AML, depending on which study you look at, in families that look like they might have a hereditary predisposition, 11 to 30% of the time we find one there. So it's a biased number because we haven't tested everyone who's diagnosed with MDS for an inherited cause. We're trying really hard. You'll see later in this presentation why it's difficult to do so. So this number is probably on the higher side, but I think when it all kind of the dust settles and it all comes out, I think about 15 to 20% of MDS overall is going to be due to an inherited predisposition. Next slide. So we have some good characteristics about, of course, when you hear this disease could possibly be passed in families or could have been inherited or passed on, the question is, well, who are the people who need to be worried about that? Is that me? Is that someone I love? So the first way that we characterize or strategize people into who might have one of those inherited forms is by the age at diagnosis. So we talked just a few minutes ago about how MDS is usually diagnosed in the 60s or the 70s. And so when anyone's diagnosed with MDS at a younger age, and we really call that 40. 40 feels young, I'm sure, to many of us, and it is young, and it's exceptionally young for MDS, and anything under 40 is also exceptionally young for MDS. So if someone's diagnosed with MDS under the age of 40, that alone is an indication to check to see if there's a hereditary cause. Also, when the doctor looks into the bone marrow, they look at something called the cellularity, which is just how many stem cells, how many cells are in there making blood, and how much and how healthy do they look. When we're young, when we're kids, our bone marrow is full of cells because we have to pump out a lot of blood, a lot of factors to get us to grow into adults. But as we get older, we don't need as much. And so our cellularity of our bone marrow starts to go down. So the rough calculation of your cellularity that you should have in your bone marrow is about 100 minus your age. So if you're 50, your bone marrow should be about 100 minus 50, should be about 50% cellular. If you're 70, it should be closer to 30. If you're 20, it'll be closer to 80. And so sometimes people are diagnosed with MDS and their bone marrow cellularity is low, meaning for their age, they just don't have the right number of cells. And that we call hypocellular MDS is also another sign that something hereditary can be going on. Next click. Of course, there are other signs, there are characteristics and things, other health problems that we might have that can go along with hereditary MDS. And I'll talk about this a little bit more, but having low blood counts for a long time before one is diagnosed with MDS can be a sign of a genetic predisposition. One of those is having thrombocytopenia or a low platelet count. There are several genes that link low platelets with a hereditary predisposition to MDS. So folks who have had low platelets really for kind of as long as they can remember and then develop MDS should be evaluated to see if it's hereditary. That kind of goes also too for anemia, a low hemoglobin, or a low white blood cell count. And this is something that comes up actually a lot with my patients because maybe they've had kind of a borderline or mildly low blood count for maybe 20 years and their doctor, it never gets worse and never gets better. So their doctor just says, oh, hey, this is just you just run low. And sometimes we can find out that the reason that was sort of running low was because of a genetic predisposition. Now, of course, MDS is characterized, it's defined by low blood counts. So having low blood counts for maybe a couple of months to a couple of years before someone's diagnosed with MDS might just be the signs of the early stage of MDS. So I usually don't worry about that too much, but we're thinking more like long time, starting in childhood or early adulthood and never really getting better. There are also some diseases that have nothing to do with the bone marrow that can run along with hereditary predispositions to MDS. Those are things like pulmonary fibrosis, which is a lung disease, causes scarring in the lungs. And if there are multiple cases in a family, it can be a sign of hereditary MDS because it's linked with one of those diseases, which we'll talk about. Also, skin or nail abnormalities, having basically absent fingernails and toenails, having a rash on the skin, having liver fibrosis. Liver fibrosis is similar to liver cirrhosis, but would occur in somebody without a very strong history of alcohol use. Birth defects, birthmarks, or recurrent infections, having weird, and by weird, I mean like opportunistic infections that people with a good working immune system usually don't get, or having recurrent infections requiring hospitalization starting at a young age. All of those can suggest that the MDS might be due to an inherited cause. Next click. And then lastly, and I shouldn't say lastly, because as a genetic counselor, to me, it's one of the most important things, is family history. So MDS, AML, and aplastic anemia are all independently and together rare. So if someone has been diagnosed with MDS and has a family history of really any relative with one of those, that's enough to look into whether it might be running in the family. It's not as worrisome if an individual has breast cancer, for example, which is so common, right? 1 in 8 women will be diagnosed with breast cancer. So it's not unusual in a large family to have multiple people who can develop something like breast cancer just by chance. But MDS, AML, aplastic anemia, those are not that, are much rarer than that. So if 2 closely related people develop one or any of those different cancers in the same family, that can be a sign that there's a genetic component. Also, being diagnosed with a family history of cancers that are diagnosed at an early age, even if it's not a blood cancer, or multiple cancers in close relatives, really of any kind, are a good indication to kind of check and see, is this possibly something that's running in the family? Next slide. Now, this is a very overwhelming slide, and you'll have access to it and you can screenshot it, but it's just meant to show you all of the different genes that have been linked with MDS. And I'm gonna go through the more common ones in a little bit more detail, but they're color-coded here a little bit. The top 3 rows, which are kind of red for blood, are associated with MDS and low platelets, so thrombocytopenia disorders. And so those link a risk of MDS with history of low platelets or sort of abnormal platelets, which I'll talk about a little bit more. In the green are hereditary predispositions to MDS that don't typically have any other blood problems associated with them. In the bottom, we have inherited bone marrow failure syndromes, which I'll talk a little bit about. We usually talk about them with aplastic anemia in childhood, but now we're realizing they cause MDS in adulthood. And what you'll see in the inheritance column there is just a bunch of AD, which stands for autosomal dominant, which is how these genes are passed in families, and I'll talk a little bit about that too. Next slide. So I'll start just by going through a little bit of the most common hereditary predispositions to MDS, so you can see a little bit about how they look in families. And I've started with adult MDS and predispositions, but some of them overlap childhood, and I'll talk about some of the common ones in childhood too. So DDX41 is one of the newer genes discovered in 2015, but is quickly emerging to be what we think is probably the most common genetic predisposition to MDS. And based on some studies we've done looking at this gene in the bone marrows of people with MDS, it seems like it probably causes about 1.5% of all MDS and AML of everyone who's diagnosed. And so that's a small percentage, but it's a significant percentage for the families that end up in that 1.5%. And so DDX41 is one of those genes that's very important in the bone marrow. It particularly sort of directs our genes being able to be transcribed to turn in to do their job and turn on and make sure that our bone marrow is doing the right functions. Now, if a family or a person has a mutation or an error in the DDX41 gene that's making it not work properly, then it increases the risk of MDS in one's lifetime in a moderate way, a mild to a moderate way, meaning that having that mutation in the gene gives a person about a 20 to 25% chance in their life to develop MDS. So this is throughout their whole lifetime, but usually starts to increase actually at a pretty normal age, like in the 60s or 70s. And when I say normal, I mean kind of normal compared to the average of MDS in the general population. What's kind of interesting, we haven't figured this out yet, and there are some tongue-in-cheek theories, but for some reason, men who carry this gene are more likely to develop MDS than women, but it's not carried on one of the sex chromosomes. So it's not linked with sex, so it's not just carried by men or just carried by women. They're equally likely to carry the gene, but men have a little bit closer to that 25% risk, and women seem to have maybe even less than a 20% chance to develop MDS. Now, this makes DDX41 a little bit hard to find, because if we could magically go back to that, 2 slides ago, you'd see that the biggest risks, the most worrisome things are young age and family history, and DDX41 doesn't really cause either of those. And so the way that this can be found in families is actually sometimes first on the molecular testing that the doctor does on the bone marrow. So when someone's diagnosed with MDS, usually we look at the chromosomes, we look at the blast percentage, and we look at gene mutations. And DDX41, if it's included on the genetic test that's done on the bone marrow, can sometimes give us a clue as to whether it might be inherited. And so this little lollipop figure of a gene is not meant to do anything other than show you that every little dot on that chart shows you a mutation that's been identified in families with hereditary MDS. And all of those would show up on any bone marrow test that includes DDX41. So it may be helpful to ask your doctor if that's been included on any genetic testing that's been done on the bone marrow, and if there were any mutations. That's one of the best ways to find this gene. Next slide. And this is a pedigree. This is what the tool we use in genetic counseling to look at families. So circles represent women and squares represent men. And you can see there are different shadings here. The numbers underneath are the age. The lines through shows someone who's been deceased. And what you can see is that there's multiple children in this family who've developed AML. The arrow on the left-hand side sort of points to the person who came to be our patient, who was diagnosed with MDS, which progressed to AML at the age of 49. She had a brother who had non-Hodgkin's lymphoma, another brother with AML in his 20s, a sister who died of AML at the age of 6, and her daughter had already been diagnosed with with MDS at age 30. And so this, you don't have to be any kind of genetics or medical expert to look at that family and just say, wow, that is just a lot of blood cancer in one family. And so when MDS and AML run in families, it can often look like this. Next slide. So this family has what is another common hereditary predisposition to MDS, which is called familial platelet disorder with myeloid malignancies. And you can tell that no one creative names genetic disorders. They're really either named after someone or they're named after what they cause. And so FPD, which we call it for short, is caused by 3 different genes, RUNX1, NCARD26, and ETV6, which were in those red top 3 rows on my table. And they affect primarily the platelets. So they cause, in almost 99% of people who have this disorder, they have a low platelet count, usually starting in childhood, even from birth, or in young adulthood. And this can be moderate or mild. So, unless you're having bruising or bleeding, we don't really know what our platelet count is, right? When our hemoglobin's a little bit low, we can tell. We feel tired, we feel maybe short of breath or a little bit fatigued. But unless we're bruising or bleeding, our platelet count could be normal or it could be just slightly below normal, and we won't know. So that can make this kind of hard to diagnose if people aren't getting their blood counts checked regularly, which if they're healthy, they might not be, and that'll be okay. So almost everybody who carries an error or a mutation in one of these genes will have problems either with the number of their platelets, too low, or the function of their platelets, not quite working exactly as they should. And they'll bleed easily with like brushing their teeth or nosebleeds, or bruise easily, bruise like a peach, as they say, if they just bump something, or sometimes they just notice bruises for really no reason. They can't remember where they got it. And these genes are important in the bone marrow regulation. So also if they're not working properly, they increase the risk of MDS to about 30 to 50% chance in one's lifetime. Now, often at a younger age, that's why young age is such a key here. So usually these genes cause a risk of MDS and AML in the 30s, but can occur as early as childhood or as old as adulthood. And so I don't always necessarily worry if there's just older diagnoses in a family. If there are multiple, it still could be due to this gene. And it can link with other types of blood cancer that are not MDS, like T-cell leukemia, but most of the time the low platelet count and the MDS or the AML are the key to kind of identifying these genes. I'll talk a little bit about this later, but screening family members prior to stem cell transplant in families that have these hereditary genes is pretty important, and we'll talk about that. Next slide. So telomere biology disorders, one of the other most common hereditary predispositions to MDS. If you haven't heard about telomeres, I have a picture of shoes up there with shoelaces, which might be like, where's this lady going? So telomeres are like caps on the ends of our chromosomes, just like our shoelaces have plastic caps on the end of them, which allow us to tie our shoes 100, 1,000 times without ever sort of unraveling the ends of the shoelace. So our chromosomes, our genetic information, have the same sort of cap. It's a stretch of really kind of like junk DNA whose only job is to protect and sort of wear down as our cells divide and protect the important genetic information on the ends of the chromosomes. And they're a little bit like a biological clock, because when we're born, our telomeres are very long, and as we get older, they get shorter and shorter. And so when we're 90, we have, tiny little telomeres, and the shortness of the telomeres gives our bone marrow, gives our cells a sign, you know what, we're getting older. We're time to shut this party down. We don't need as many blood cells. Maybe, it can start to lead to problems in the bone marrow and can lead to MDS, which at an older age would make sense. But if there's a problem with the genes, there's a whole team of genes that maintain those telomeres, like little maintenance workers, come in and make sure that the telomeres don't get too short too fast. If somebody inherits a genetic problem with one of those maintenance worker genes, then what happens is that the telomeres get too short too quickly over time, and that can lead to the increased risk of MDS or other bone marrow problems. Next slide. Now, telomere biology disorder used to be called dyskeratosis congenita, and it still is by many doctors, many genetic counselors. And so if you've heard of dyskeratosis congenita before, telomere biology disorder is the same thing. We're moving away from that name because the classic form of dyskeratosis congenita was usually just diagnosed in childhood, thought to affect only boys, was very severe. But now we know that the milder forms with some specific genes like TERK and TERT actually really just affect adults and can run in families, causing a risk for MDS and also that pulmonary fibrosis, which was on that earlier slide. And as the more we learn about this adult form, the risk of MDS appears to be about a 30 to 50% chance in one's life, but can also just cause low blood counts or recurrent infections. Next slide. I like this slide. I think it's pretty cool because it just shows you what short telomeres look like under the microscope. So on the left-hand side, you have an 18-year-old, and those little white dots on the ends of the blue chromosomes that are super bright are showing you nice long telomeres. On the right-hand side, you can see somebody who has a telomere biology disorder at 10 years old, and you can see those lights are much, much dimmer, and there are even some chromosomes where you don't even see that signal at all. And that's the test that we do. This is how we can find out whether short telomeres might be the cause of someone's MDS. And Fanconi anemia, you can't talk about hereditary MDS without Fanconi anemia, although I'd be surprised if you haven't had webinars on Fanconi anemia before, which is really one of the most common childhood causes of bone marrow failure, aplastic anemia. But like dyskeratosis congenita, like that telomere biology disorder, we are learning that Fanconi anemia can be mild and actually cause MDS in adults. So up to 40% of Fanconi anemia, which usually causes birth defects and short stature and bone marrow failure in very young children. If people have the milder form, they usually they don't have birth defects, they don't have blood problems in childhood, and then they get into adulthood and the risk of MDS can occur as a young adult, like an adolescent or even young adult, 20s, 30s. And it's still caused by Fanconi anemia, the same sort of recessive genetic cause that has to come from both parents. And so you can check adults with MDS for Fanconi anemia by a blood test, which looks at chromosome breakage. And just like in children, we use stem cell transplant to treat that, but in adults, it can also be associated with squamous cell carcinomas of the neck, and by the neck, I mean inside the neck, like the mouth and the throat and the tongue. And those are important to screen for and can be signs of Fanconi anemia. Next slide. There are two different genes, these are brand new, that have been identified with really MDS in children. So MDS is very rare in children and adolescents. So it really is anytime a child or an adolescent gets MDS, genetic testing is recommended because the risk of an inherited cause is pretty high. If you're not in your, if you haven't lived 60 to 70 years, you can't really have been exposed to things long enough as a kid to get MDS. And so the question is, could this be, an inherited disorder? Now, the gene GATA2 is really important in our bone marrow, primarily related to our immune system. So it's one of the bone marrow team members that's really important with white blood cells. And it tells our bone marrow to make monocytes, natural killer cells, those white blood cells that are really key to fighting bacterial infections and fungal infections and all the different infections we can get. Now, in people who have a problem or a mutation in GATA2, which causes this GATA2 deficiency, that makes people really susceptible to infections. And it can be infections that typically we don't see in the general population, like mycobacterial infections, which working immune system's not even going to recognize. It's going to see them, it's going to clear it, and you never even know you have it. It just doesn't affect people who have a working immune system. And so recurrent infections, sort of weird or atypical infections that don't clear up very well, are associated with GATA2 deficiency, as well as probably what we believe to be the highest risk of MDS and AML, up to a 70% chance, primarily in kids. And it is the most common cause of MDS in children with MDS who have a monosomy 7, which means under the microscope in the bone marrow and the chromosomes, they're missing a copy of chromosome 7. That's very closely linked with GATA2 deficiency. Basically, 3 out of 4 kids diagnosed with MDS who have monosomy 7 in the teenage years are going to be due to this inherited gene. And this has only been discovered, this was reported in really the early 2010s. Is that a thing? 2013, 2014, so it's new. Next slide. GATA2 can also cause things that have nothing to do with the bone marrow, which is why we don't just ask about blood disorders or MDS and AML when we're taking the family history. GATA2 can cause hearing loss, it can cause lung disease, can cause, of course, low blood counts, MDS and AML. It can cause warts, extragenital warts, so like warts on the hand or on the feet, can cause lymphedema, which is like an unequal swelling of a limb. You can see here the left leg is swollen. Lymphedema can also be a sign of GATA2. Of course, lymphedema can be happening too when you're in the hospital and they hook you up to that hydration and they leave it running for 24 hours and your limbs kind of get swollen. That's different. This would be, lymphedema that happened before any other signs of blood cancers. Next slide. And the last gene I'll talk about just specifically, and of course, we could have a 2-hour-long webinar on all of these different genes and how they work, is really the newest genes on the scene for pediatric MDS, which are SAMD9 and SAMD9L. These are so new that I went to a global congress on these genes at St. Jude's last year, which was only about 20 people, including the people who discovered these genes just a couple of years ago. So SAMD9 and SAMD9L are two very, very similar genes. They differ only slightly, that predispose to MDS. And SAMD9 causes other problems besides MDS. It causes something called Mirage syndrome, which stands for myelodysplasia, MDS, infections, restriction of growth, which usually means very small birth size or birth weight, small adrenal glands, genital abnormalities, and enteropathy, which is like GI problems. And SAMD9L causes a balance issue. So it causes ataxia, which is an issue with balance, affecting a part of our brain, the cerebellum, that controls balance, and increases the risk of MDS and AML. So if you have a family history of a young child with MDS whose mom maybe had to use a walker, or grandmother ended up in a wheelchair at a young age, or had balance issues, sometimes this can also be pointing towards an inherited predisposition. And like GATA2 deficiency, this in a very unique way, which I will not bore you with today, also predisposes to monosomy 7 MDS. So that monosomy 7 marker in MDS in those chromosomes is a very kind of close link with hereditary disorders. Next slide. Okay, checking my time. I know y'all said I could take my time, but I don't want to get too far over. So every predisposition that I talked about, except for Fanconi anemia, is what we call autosomal dominant, which means it can be passed and is passed directly from parent to child. So in this figure here, you can see the dad has on the chromosome a pink arm and a blue arm, and that pink or that red stripe represents the genetic mutation that he inherited. And then you have the mom who has 2 normal copies, or 2 normally working copies of the gene. When they have children, when we have kids, right, I don't know about you, but you usually don't sit down and hand select which genes are going to be passed on to which children, right? It's a random occurrence. Each parent gives 1 copy of each gene. And so a child ends up with a full copy, a full complement of the right genes, but they get 1 from mom and 1 from dad. So in this case, with the dad carrying this gene linked to MDS, there's a 50-50 chance that that could be inherited from his children. He could pass on the red copy that he has that causes the disease, or he could pass on the blue copy, which is normal. And so each of that's an independent chance. So it's not that 50% of the kids will inherit it and 50% won't, but instead each child of somebody with a hereditary predisposition to MDS has an equally likely 50% chance to have it or 50% chance not to have it. Now, the thing that's interesting about this and reassuring about this is that these genes can't skip generations. So if you look at those 2 unaffected daughters and unaffected sons in the middle of that figure there, they only have blue stripes. So they only have a normal copy of the gene to pass on, which means it can't skip a generation. They are not at a risk to have a child who has the hereditary predisposition if they didn't inherit it themselves. Next slide. So we'll talk a little bit about why it's important, besides just understanding, to find these hereditary predispositions to MDS. Next slide. So of course, it can be very scary to think about the fact that you or a loved one developed MDS due to a hereditary predisposition, but it can also answer a lot of questions. I haven't really met anyone who hasn't had, that one night where they're laying there thinking just like, why did I get this? Why me? What did I do? What did I breathe? Or did I do anything? What is this bad luck? And so finding out that somebody carries a hereditary predisposition can answer a lot of questions. It wasn't anything you did. It wasn't anything you were exposed to. It was just a predisposition that was inherited in your genes, that even if you were, a vegan marathon runner who, never exposed yourself to anything, could still develop it because of that genetic predisposition. But it can also help guide treatment. So we're learning that these hereditary MDS predispositions can respond differently or even better to some types of therapy than counterparts that don't have those hereditary causes. For example, in telomere biology disorder, androgens, can be used to help support low blood counts, which work very well to recover low blood counts in those patients. And DDX41 is seen to respond pretty well, not long for a long time, but for the short term, pretty well to certain types of drugs that wouldn't normally work in somebody without DDX41. So it can give your doctor some additional treatment options if it is hereditary. Next slide. One of the major ways this helps is in stem cell transplantation. So as you know, stem cell transplant is often recommended to some people with MDS as a form of a treatment, even a cure for the disease. And the best stem cell donors have closely matched immune systems, and the people who are the most likely to have a good closely matched immune system are our family members. But in families where MDS is running through the family, we want to be very careful that we don't transplant the gene that caused the MDS in the first place back to the family, back to the patient with MDS that we're trying to cure. And so one of my major jobs at MD Anderson is making sure that if we identify that MDS is hereditary, that we screen any family members before transplant to make sure that we're not giving back the same genetic cause in the first place, and that we're helping those family members understand their risk and making sure the transplant has the very best possible outcome. There are also, depending on the gene, different drugs that should be used for transplant to help reduce side effects and to increase the transplant's success rate. So this has been really emerging as one of the ways that we're improving transplant outcomes in people with MDS based on genetic testing for the familial cases. Next slide. And of course, if somebody is going to be a stem cell donor, genetic counseling is recommended before that to talk about the gene that's in the family. But of course, for anyone who's interested in genetic testing for MDS, genetic counseling is important because we go over, the chances of having the gene that predisposes to MDS, how the testing's done, that genetic testing is optional. And if family members don't have a diagnosis of MDS, they can, if you're attending this webinar and you have a family history, but you yourself aren't affected, you can still have genetic testing done and still meet with a genetic counselor. Next slide. So how do we test? Let's get into that. Next slide. So you are probably all familiar that a lot of different tests are done when MDS is diagnosed. We look for genetic mutations, chromosomes, blast percentage, all of which are telling us about the MDS itself. But the problem is that MDS almost always has genetic mutations in it that have nothing to do with what you were born with. These are genetic mutations that are acquired in the bone marrow, not inherited. They weren't there when you were born. They just got picked up in the cells in the bone marrow as the MDS was forming. So they're going to be in the blood, they're going to be in the bone marrow, but they weren't inherited. So they can really confound us when we try to do genetic testing. Next slide. These are just the genes we test for example, at MD Anderson on the bone marrow. And so if we can click through, Julie's going to click through for me. So for example, you can have mutations in the gene DNMT3A, SETBP1, a lot of these genes, they don't run in families. So we can click, never have to worry about those. And we can click again, but you can see DDX41 and RUNX1 are on this list too. Those can be present in the bone marrow because they were acquired, but they could also be there because they were inherited. And it's impossible to tell by looking at the bone marrow whether they were inherited or just acquired. And so therefore, click, next slide. We have to test something we have to test a sample from folks with MDS that doesn't have the contamination of those genetic sort of noise. We don't know, we can't tell from the blood if that's real, meaning like if it was inherited or if it was acquired. And so what we have to do is get DNA from a tissue that's not blood or bone marrow. And so the easiest thing to do that, really we could take it from anywhere, but like no one's signing up for a liver biopsy or like a lung biopsy. So what we typically do is a skin biopsy. We have to take a little piece of skin, it's about 3 millimeters, from anywhere on the body, which is going to have all the DNA that you inherited from your parents and passed on to your kids, but it's not going to be contaminated by any of the chromosome problems or mutations that we see in the MDS. Next slide. So a skin punch biopsy is very similar to having a mole removed. It's a quick procedure. It takes about 5 minutes, and 4 of that is setting up. It's sterile, and it's also safe for people even if they have low blood counts. There's a very small risk of bleeding or infection, but we've done over 600 skin biopsies for patients just for hereditary MDS. I'm knocking on my wooden desk, and we've never had an infection or a complication, so it is safe. And then the DNA that comes from the skin cells represents the inherited genes, and that will tell us whether someone was born with one of those mutations that cause their MDS. Next slide. Next slide. So if an individual, so if somebody already has MDS and they get genetic testing and we find out that it's hereditary, of course we can use that information to make treatment decisions, to make sure we're getting their best donor for transplant, and have a better understanding sort of psychologically of just why did this happen? Why has this happened in other family members? But family members who don't have MDS can also undergo genetic testing to see if they're predisposed. And if they don't have a blood cancer, they don't have to go through that skin biopsy. They can just have a blood test. But most of the genetic mutations, since they only mildly or moderately predispose to MDS, it becomes about monitoring. So it becomes about doing the right tests to sort of personalize treatment for family members who may or may not develop an MDS down the line. Next slide, please. So a point I just missed on my last slide, but this is the most important point, is that carrying one of these genetic mutations increases the risk of MDS, but in no way guarantees a risk of MDS. So none of the genes that are linked with MDS cause it 100% of the time, which means even if family members get genetic testing and find out they carry the gene, that's only telling us that there's a chance of it, not that it'll definitely happen. And so the way we can monitor to see for any changes is, number one, just starting with blood counts. Just checking blood counts twice a year. A single low blood count on a given day doesn't really matter. It doesn't tell us much. It just tells us about what that bone marrow might be dealing with. But the more important thing is checking those blood counts over time. So checking them twice a year with a hematologist who knows what they're looking for is important. And we'll often recommend that when that gene is identified in that person who's healthy, that we do a baseline bone marrow biopsy. Now, we don't actually recommend bone marrows for the general population, of course, because we can't even get people to get mammograms, let alone just sign up for a bone marrow biopsy just to check. But if we know someone carries one of those predisposition genes, a bone marrow can be so helpful because we can actually see changes in the bone marrow that might be leading to an MDS before someone ever has low blood counts or any symptoms. And so that allows us to start maybe with early therapies, or maybe we see a chromosome change that's saying, oh, this is on the way to an MDS. And then we can start doing things like setting up for a stem cell transplant or things before it becomes an emergency, before chemotherapy might be needed. And to kind of, like I tell my patients, to kind of just be one step ahead, even though there's nothing we can do at this point to fix any of these genes. So there's no gene therapy, there's no way to stop the gene mutation from being present, but we can kind of learn that it's there and know to be one step ahead. Next slide, please. So in summary, just to take away, I've talked a lot and hopefully it's been clear, but the most important takeaway points are that MDS almost always happens by chance and almost always doesn't run in families. So it's really, most MDS is not hereditary, but up to 1/3 of patients might have an inherited predisposition, and that can be critical to find out related to treatment recommendations, stem cell transplant donors, and in the case of things like pulmonary fibrosis or squamous cell carcinomas, it might actually give us information about things we need to be looking for that we can prevent or be ahead of that we might not otherwise know about. Of course, then it also tells us whether family members might be at risk, so they can identify that if they'd like to for themselves. And this genetic testing is available. So it is done. It is at a bunch of laboratories in the country, and you can talk with your doctor or a genetic counselor at your hospital about whether you might qualify. And of course, genetic counselors are always available there to help you estimate what the chances are that your or your family members history of MDS is hereditary, how genetic testing can be done for you at your hospital, how exactly it's done, insurance, all those sort of things. Someone is always available to help. And if you have questions about this or think that your family might be a good one for evaluation, then I encourage you to talk about that with your doctors. And with that, I will wrap up. I only went over by 4 minutes, which is actually pretty good for me. And I'm delighted to answer any questions.
Well, thank you so much. And we do have a few questions. Our first question is, who passes on these MDS genes, mother, father, or both?
That's a great question. So none of the genes linked with MDS are on the sex chromosomes, the X and Y chromosomes, which are the only chromosomes that differ between men and women. So men and women can pass these genes on equally. So if a woman or a mom carries this gene, it can be passed on 50-50. Same with dad. It just kind of depends which side of the family it's coming from, but it can come from either side.
Thank you. This question comes from the, it says, my dad had AML. Is there a connection with having the same blood type?
Good question. There's no link so far as we know with having the same blood type. So of course there's only really, let's see, A, B, O, B. There are a very limited number of blood types in the general population. So basically you share a blood type with every 1 in 5 individuals, plus or minus, positive or negative notwithstanding. So as far as we can tell, there's no link between blood type and risk for blood cancers in the general population or in families that have these inherited genes. So the blood type is not going to increase or decrease your risk.
Thank you. Can mutations in RUNX1 occur spontaneously later in life, or are mutations in this gene always hereditary?
That's a great question. So they can be both. That's why that bone marrow test can be misleading. So our blood acquires genetic mutations throughout our lifetime. So about 5 to 10% of people over the age of 60 or 70 will start to get some abnormal genetic mutations in their bone marrow, simply because our bone marrow has been dividing for 60 to 70 years and it just starts making some mistakes. So RUNX1, that RUNX1 gene, can occur later in life as one of those sort of accidental genetic mutations in the bone marrow that wasn't there from the beginning. It can't be passed on. It just happens in the bone marrow, and it can be one of the sort of steps that leads to the development of an MDS. So if it gets acquired, it sort of creates an environment in the bone marrow that can lead to an MDS. And it can be inherited. So you can also have a gene mutation in the RUNX1 gene that you're born with, that's passed from one of your parents, that's there from the beginning, that predisposes to MDS. So if somebody, you can't tell by looking at a bone marrow report whether a RUNX1 mutation was there from the beginning or if it was acquired, unless you check something that's not the blood, which is why we do the skin. But in a study we looked at RUNX1 mutations to see how often, if we saw them in the bone marrow when someone was diagnosed with MDS, how often were they hereditary versus how often were they just acquired. And it's only about 20 to 30% of the time that they're hereditary. So most RUNX1 mutations we see in the bone marrow are actually those acquired ones later in life, and it's the minority that were inherited. But that's what kind of makes this particular area of genetics kind of confusing, because MDS and AML patients get real familiar with mutations because we test them, but the majority of the mutations that we see in the bone marrow are not going to be inherited. They were just acquired.
Thank you. This question reads, if my father had MDS at 84 and my 17-year-old daughter had MDS monosomy 7, would it make sense for me at 57 and my son, who was 28, to get a genetic test for predisposition to MDS?
I think so. Yeah, I think so. It really does come down to, whether you'd like to know that information. I think, that pattern, the monosomy 7 and the young age of your child, and kind of, your position with that link between your dad and your child certainly is suspicious to me. Of course, without knowing the rest of the family history, it's hard to say, but I would definitely encourage you, if that's on your mind with that pattern, you would be a good candidate for genetic testing. Now, since you're the link between your mom and your child, your father and your child, you're the best person to have the genetic test first. So I wouldn't test your son right away. I would test you to see what are we dealing with here, if anything, and then your son could be tested based on what's found. But I think, going back to that early slide, that pattern in the family is exactly, the type of pattern that could suggest something that's running in the family, and a great question to give to your daughter's doctor or your own doctor about somebody that can coordinate that for you.
Thank you. Do you know if genetic testing is part of the process at all transplant centers?
It's not. I, along with the doctor I work with at MD Anderson and one other doctor in the country, are on a very passionate awareness campaign. So I gave a talk to the American Bone Marrow Transplant Society in 2017 or 2018. And it was the first time that many of the transplanters at that conference had heard of hereditary predispositions to MDS. So it's not. It is a growing awareness. So it's a partnership. It's a teamwork between the transplant department and the leukemia and the hematology departments. But it is growing in awareness, and boy, wouldn't it be great if a question you could bring back to your hospital and your team was, hey, do we do genetic testing here? Do I qualify? What if my, because that's another way that we can continue to bring awareness. So it's not standard, but any doctor can order genetic testing if they know how to, if they can do a skin biopsy, which any doctor can. So it's not standard, it is growing, and any questions that anybody asks of their doctors and teams are just more ways to bring awareness to start helping to get that to be more of a standard thing.
Thank you. This question comes from a parent whose 10-year-old child has been diagnosed with MDS. They would like to know, should they suggest having the younger siblings tested for MDS for predisposition?
Yeah, that's a great question. If your 10-year-old with MDS if it's possible, genetic testing in the child who has MDS first is key. Because many childhood MDSs are hereditary, but not all of them. So if that genetic test came back negative, then you wouldn't have to even worry about the hereditary risk in the other siblings. So a good step would be to test the family member with MDS first, see if it even is hereditary, and then you'll know whether or not to test the other kids. Now, if it is hereditary, it comes back hereditary in the 10-year-old, well, then it's good to have a conversation with the other kiddos and with their doctors about testing them for the gene. I would say when it's a gene like GATA2 or Fanconi anemia or those other sort of SAMD9, those childhood things, we usually do test the other siblings, one for transplant purposes, but also so that you can know, whether or not they need to be getting their blood counts checked, whether or not maybe they might benefit from having an immunology doctor, if they might be getting infections. So I think that a good place to start would be talking to your child's doctor about genetic testing for your child with MDS. Now, if unfortunately your child with MDS has passed away or wouldn't be able to get the genetic testing, or for some other reason, then it could be reasonable to test the other children or to test you and your partner, the parents of the child who had MDS, to see if it was hereditary. That's another option.
Great. Thank you so much. We have a question that says, could you talk a little more about monosomy 7 and the hereditary link? Do you have some additional information that you could share that you had not shared in the presentation?
Yeah, so monosomy 7 is is not a common chromosome problem with MDS, especially in adults. It's a little more common in children. But it is a lot of chromosome 7 is home to a lot of really important genes that protect against MDS that are, you know, really important in bone marrow. So I have my little chromosome 7 here with my fingers. I might still be small, but at SAMD9, SAMD9L, and several other genes are located on chromosome 7. And so for SAMD9, for example, I'll give you just an example. SAMD9 works like a car. So this gene of SAMD9, when it's working properly, it is brakes on a car. It is telling our bodies, it's telling our cells, slow down, basically protects our cells from dividing too quickly. When our cells divide too quickly, they make mistakes, and genetic mistakes in quickly dividing cells are basically cancer. And that's the definition of cancer. So the purpose of SAMD9L SAMD9 and SAMD9L is to activate those brakes to make sure cells don't divide too quickly and that they don't make any mistakes. When there's a mutation in that gene that's running in families, it actually amplifies the effects of the brakes that it's putting on the cells. So the SAMD9 gene makes the cells be like, the mutation makes the cells be like super stopped, like do not divide, you know, you can't go, we are braked, we are shut down, break. Now, the bone marrow hates that. The bone marrow wants to be constantly making cells. So our bodies are crazy. And by crazy, I mean wild and amazing, but also just crazy. And our bone marrow can actually change its genetics to get rid of that effect that's trying to slow it down. So what it often does is we have two chromosome 7s. One's got the SAMD9 mutation that's making it very hard for the cells to divide. The bone marrow will actually kick out the copy of chromosome 7 that has that mutation. I mean, wouldn't it be wonderful we could do this with things we didn't like in our lives? It just kicks it out. It says, you are holding me back, girl, and it gets rid of a copy of the copy of chromosome 7 that has the mutation, which leaves you only with one chromosome 7, monosomy 7. And so the monosomy 7, once you lose that second copy of the chromosome 7, is a very, very bad, and by bad I mean it's just a very predisposing situation in the bone marrow to lead to MDS. So it's actually a lot of the ways that GATA2 and SAMD9 and SAMD9L work in the bone marrow to lead to monosomy 7 is that's the bone marrow's response of getting rid of the genetic mutation. It's actually trying to rescue itself and give itself a better advantage. But in doing so, it kind of creates a scenario that increases the risk of MDS. I wish I had some slides to make that a little bit clearer, but I hope that's clear. That's also why monosomy 7 is one of the more sort of concerning signs for an inherited predisposition, because so many of these genes that cause monosomy 7 are on chromosome 7. So it's just doesn't mean all monosomy 7 MDS is hereditary. It definitely doesn't mean that, but it is sometimes a monosomy 7 can happen as a bone marrow's response to try to get out from under the thumb of the genetic mutation that's there.
Thank you. And we did have a comment that says, thank you for this excellent presentation.
You're welcome.
Thank you so much, Sarah, for taking the time today to share your expertise with all of us. And we know that this is a very concerning topic for all MDS patients.
Yeah.
If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If for some reason we were not able to answer your question today, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, submit a question on our Facebook page. I would also like to note that we are hosting a National Patient and Family Conference next weekend, and there will be lots of conversations with MDS experts and some other topics, as well as we'll be having an MDS support group for patients Saturday evening. And you can find more information about this upcoming event on our website, which is aamds.org. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AA-MDS-IF Medical Advisory Board and team are here to help you and your family as we have for the past 36 years. This concludes today's program.